Good evening to respected chairpersons, moderators, and colleagues. I'll be talking about the procedure steps for image acquisition, which is very important because if you don't follow the proper procedure steps, then it can interfere with the quality of image acquired, and that can interfere with the image analyzed, treatment taken, the decisions taken, and ultimately the outcomes. First, we'll come to the patient preparation. Since the introduction of IVS catheters involves the introduction of catheters and wires inside the coronary arteries, the procedure has to be performed under full anticoagulation. All the patients should receive a hand fraction heparin to maintain an ACT of more than 250 seconds. The commercially available IVS catheters range in size from 2.6 to 3.2 French. So only guide catheters should be used. If you use diagnostic catheters, can produce friction and can interfere with the image acquisition. All the IVS catheters are 0.014 inch wire compatible, so any workhorse wire is perfectly okay. Since the introduction of a catheter can provoke spasm, so typically the examination starts with the administration of a vasodilator. Most of the cath labs use intracoronary nitroglycerin at a dose ranging from 100 to 200 microgram bolus. Now we'll come to how to prepare the catheter. As the previous speaker mentioned, there are two types of catheters in commercial use. One is the mechanical IVS system, prototype is the Boston Scientific, and a later generation of Philips systems. It has got an outer shaft and a central outer sheath and a central shaft. And these are the landmarks. You have a distal marker which lies variable length. In Boston Scientific, it lies about 5 mm from the distal tip. In Philips system, it lies about 10 to 20 mm from the distal tip. It helps to place the catheter safely in the distal vessel and helps the distal vessel damage. One disadvantage, as already mentioned, is that there can be air bubbles that can be present between central shaft and outer sheath. And how I will describe how to remove the air bubbles. These are phase array systems. Phase array system comes as a single shaft. You need to just wipe with a heparinized saline before introduction into the coronary arteries. We'll come to the catheter preparation. These are the videos that show how the catheter is prepared. All the steps has to be performed under strict aseptic precautions. And this is, I'm just showing how you to remove the air bubble. And once the catheter is out of the housing, we have to prepare the connector. The connector you can see on the right side of your screen. You have a reservoir, which is a 10 cc syringe, and a flushing syringe, which is a 2 cc syringe. And first we have to remove the air bubble from the connector. That's how it is done. Once the 2 cc syringe is emptied, you can fill it from the reservoir. And after that, you can connect it to the catheter, and you can start flushing with the 2 cc syringe till no air bubble exit from the distal port. That is shown in the video on your right side of the screen. So that's how the operator flushes it, and no air bubble exits. So make sure that no air bubble remains there. It can interfere with the image acquisition. It can scatter ultrasound waves and can produce false shadowing. That's how it's done. Then once it is prepared, we have to connect the motor drive unit. A motor drive unit is an unsterile thing, so we have to make it surrounded by a sterile paper. This is a sterile cover which is supplied along with the system. So it comes with multiple folds. The operator can catch hold of the innermost fold, and the technician can hand over the motor drive unit and can pull back the cover so that the motor drive unit gets covered by the sterile cover. So that's how it is done. So the motor drive unit is handed over, and the technician will pull back the cover so that it gets covered by the, then it is fit to be placed in a sterile environment. So once the operator places the wire and parks the catheter at a site where he intends to touch the pullback, there are two choices. One, he can make a manual pullback, just pulling back the catheter, or you can have an automated pullback. This is a device which is used for automated pullback. It is called sled. You can connect the motor drive unit onto a sled, and a signal appears. That means that the motor drive unit is firmly connected to the sled. So once it is connected, you can connect the catheter onto the port provided, and you can fix onto the groove which is provided along with the sled. So that's how it is connected. And you have a red mark there on the outer sheath of the catheter. You can fix it onto the groove on the sled, and once the motor drive unit is activated, the motor drive unit will start pulling back the inner shaft, and that's how the automated pullback is ready. This assembly is ready for an automated pullback. Now that's how it is done. The display will provide you how far you have pulled back, and this is very important, and this is displayed as a longitudinal mode on the monitor. This is very useful to estimate the length of the lesion, and also it provides some information in complex interventions like bifurcations. You can decide what is the bifurcation angle and so forth. Now we'll come to the console preparation. This is how a console looks like. You have different parameters. You can set the recording speed. You can either record at 0.5 millimeter per second or 1 millimeter per second. You can choose which way it has to be displayed, and most importantly, you can adjust the brightness. Because if it is too bright or too dark, then that can interfere with the image acquisition, and there can be false dropouts, and that can interfere with your decision. And in some cases, there may be large vessels, especially left main, which may not conform to the sector of imaging. So in that case, you can adjust the depth and make the vessel conform to the sector of imaging by adjusting the depth of the sector. And these are some other important settings which we can adjust. We can have a near field suppression, we can have far field enhancement, we can suppress the speckling, which can be problematic in patients who have slow flow, and this can interfere with the luminal assessment. And lastly, most importantly, we have to assess the plaque characteristic in a dark environment. These are two images, which are one where it is assessed in a dark, and one which is where the light is reflecting onto the monitor. If you have a light reflecting onto the monitor, it can produce false brightness, false dropouts. That can interfere with the luminal assessment and other parameters. So it is important that as far as possible, the images has to be assessed in a dark environment. So I would like to conclude my talk by these pertinent points. Only guide catheters for IVUS pullback. It has to be performed under full anticoagulation. ICT should be more than 250 seconds. Sterile precautions will be followed, and mechanical catheters need to be freed from air bubbles before introduction, and better to analyze the plaque characteristics in a dark background.